Hello, everyone. This is Dr. ElKhory with Neurocare and Slidell Memorial. I'm the stroke director at Slidell Memorial. And we'll be talking today about VAN scoring and the importance of VAN scale or score for stroke management. Really, the reason the VAN score is done is to discuss for management of large vessel occlusions. So what are large vessel occlusions? So in the brain, there are large vessels that supplies it. Large vessel occlusion include intracranial carotid artery, middle cerebral artery, anterior cerebral artery, and posterior cerebral artery. Large vessel occlusion are associated with stroke, with high severity, with high disability, and worse clinical outcomes. They are usually associated with NIH stroke scale of 6 or more, and they need to be identified very, very early and very quickly. Why? Because recognizing these patients can and will most likely improve outcome. The number needed to treat for endovascular therapy within 24 hours of symptoms dependent on the study and the timeline can be anywhere from 3 to 6. So really recognizing and treating the patient is giving our population the best opportunity for outcome. VAN scale or VAN scoring system is associated with high sensitivity and specificity to recognize these large vessel occlusion. They are based on cortical findings. Everything starts with looking for hemiparesis or weakness. You ask the patient to raise their arms straight like this, and then you wait, and you count for 10 seconds. If there's any weakness on any side, then then you go for the VAN screening. If there's no weakness, the patient is VAN negative. If there is weakness, then you go to the VAN. If any of one of the three is positive, then the patient is VAN positive. So V is vision. If patient has a field cut, if they cannot see on the right, if they cannot see on the left, if they have diplopia or double vision, or if they have disconjugate case, meaning the eyes don't look straight, or if they are blind and suddenly in one eye, then the V is positive. A is for aphasia. Aphasia is a cortical finding. It's associated with speech and understanding. There is production of speech, which is expressive. You ask the patient to repeat after you or name 2 objects. Receptive, you ask them to follow commands. For example, close their eyes, make a fist. This is the receptive part, and they can have both receptive and expressive aphasia. N is for neglect. If the patient is looking on one side, then has a gaze preference, then it's positive. If you touch both sides and they cannot feel one side, then it's positive. If they cannot recognize their own side of the body, then it's positive. If they're ignoring one side or neglecting one side, that's positive too. Very important to screen for VAN score as soon as the patient arrives with suspected stroke. Time is of essence, and VAN positive patients need to be identified as soon as possible. We are here at any time if you have questions. Thank you very much.